having done surgery for prostate cancer for the last 30 years, one of the trickiest parts of the operation, whether you do the perineal approach, which is down from below underneath the scrotum but in front of the rectum, or whether you do the open above approach, the suprapubic approach, has always been getting the prostate off of the rectum because it's so close and sometimes even adherent to the rectal wall. And so I know one of the things that you try to do is avoid rectal toxicities.
Absolutely.
And so in the last year, and I'm mentioning this because we have Jerry here and the folks from SpaceOAR, they are one of the modalities that are available that have been developed to try and find a way to decrease rectal toxicity. Now, when I first read about it, I thought, this is really stupid. But the well, you read things. It's like the first robotic prostatectomy. I thought it was not legitimate either, but that's another story unto itself, and now it's the mainstay in therapy for surgical approach. But after you read the data on things like SpaceOAR, it's pretty impressive when you look at that. And so how do you decide who's a candidate for rectal spacing?
So I consider it in pretty much any patient that I'm going to be treating with external beam radiation. MRI figures into this as well, given the proximity of the rectum to the prostate, which is exactly why you would use the rectal spacer. One thing that I make sure of on every patient before I offer it is that there is no growth of the tumor into that space where you're going to be injecting the hydrogel. Are you guys familiar with what this is?
I don't think so.
Okay, so why don't we take a minute
Sure.
and sort of describe what this is. So, well, without other visual aids, prostate here.
Do you want me to act like the prostate for a second?
No, please. Prostate here, rectum is right here behind it, and we all know how close the prostate is to the rectum, how we feel for your prostate. So there's this little space in here between that's very tight. So we actually introduce this the same way that we would introduce a brachytherapy needle if that's what I was doing, where we go through the skin of the perineum, so behind the scrotum, in front of the rectum. But with brachytherapy, we're guiding the needle into the prostate. Here we're guiding the needle behind the prostate. You inject that space with a mixture of two liquids that when they combine, they solidify into really, it's a jello-like material that all it does, once it gets into that space, it's going to augment it. So it's going to basically take it from here to here. And those extra 5 to 10 millimeters that you get when you're designing a radiotherapy treatment can make a huge difference in the dose to the rectum, especially with the very high precision modalities that we use now. So what I want to make sure of in the MRI, I wouldn't, if someone has very low volume or very early stage disease, I will put spacer in without it. But most of those patients who are very early stage, very indolent prostate cancer, we don't even see them anymore. You guys see them and appropriately recommend surveillance. So it's rare for me to see those patients now. So I get the MRI, I ensure that there's no cancer growing out the back of the prostate, not invading into the rectum, that would be very advanced disease, but just making sure there's not a high risk of there being tumor cells in that space where I go in with a needle, inject the spacer, and now I'm separating cancer cells from my target, which is the prostate up here. So if I see that growth, I won't offer the spacer. But anybody who doesn't have that, there's very good evidence to suggest that by using spacer in the context of external beam radiation therapy, you do reduce the severity of the rectal side effects.
And the nice thing about the spacer is it's reabsorbable. So it's not a permanent gel that stays inside your body. It's reabsorbed over a period of 6 months, and by 12 months it's fully gone. So you'll never know it was there.
How long have we been doing the spacer?
Not that long.
At Beaumont, we've been doing it for probably, I want to say it's been close to 2 years now that we've been doing it. It was a very natural fit for our program, though. With our brachytherapy program, we're very accustomed to sticking needles in that area. And really, mechanically, it was a procedure that was really very easy to adopt.